Good evening, everyone. I am Dr. Sachin Patil, along with my co-moderator Dr. Rishi Loda sir. I would like to welcome you all on this MAHAIP's academic platform. Today is the Friday Ka Punch MAHAIP Ke Sang. It's episode 11. We are thrilled to discuss the neonatology in pediatric office practice tonight. So let's get started. We have an amazing lineup of experts as well as speakers tonight. Now I request our respected MAHAIP President Dr. Sanjay Pakmode sir to give an address for the delegates and speakers and experts. Over to you, Sanjay Pakmode sir.
Thank you, Sachin. Namaskar. Now, welcome to the MAHAIP platform. As we are reaching to the concluding session of our tenure, another 2 weeks, less than 2 weeks. So in this whole year, I think we have done lot of academics where we have learned a lot. We shared that same goal of child survival and the child health. And the same will be continued in the next year, that is on the 2026. Neonatology, as we think, is not a subspecialty of pediatrics at all. When you become a pediatrician, neonatology is a part and parcel, whether you work in a tertiary care center, whether you work in a very remote place, or whether you work in a private setup. You need to be updated about the neonatology, because every pediatrician starts his practice with, after this, he gets a chance to see the newborn, whether he's practicing pure pediatrics or whether he's having his own NIC, or he's working in a very corporate sector. So we need to be updated, always updated about the knowledge of neonatology. Now that we understand from the topics today we have been selected in the neonatology, that the first few minutes, hours, and even the days of the newborn life are very vulnerable and often most decisive. Over the last few decades, neonatology has done witness a remarkable progress and survival of the extremely premature babies. Because of advance in the treatment of neonates, whether it is a nutrition part, whether it is the respiratory support, whether it is the initial stabilization, or whether it is a long-term control and long-term outcomes also. But with this, so many responsibilities came to us with these advances. These advances have brought so many responsibilities toward the neonatologist and the pediatrician. Ethical decisions, long-term follow-up, family counseling, and integration of neonatal care into pediatric practice. In the country like India, where the relevance of neonatology is very much, because we have just listened what is the neonatal mortality rate at Merghat. It is rising, very surprising. In spite of advancement in our knowledge of better care, still we are facing a neonatal mortality rate on the higher side, which was very much discussed in the winter session of Nagpur Assembly. So there is a lot need to be done in that neonatology. And we know that the common problems of prematurity, birth asphyxia, low birth weight, sepsis, they are always there as far as our country is concerned. And neonatology is a teamwork. It's a teamwork between the obstetrician, pediatrician, a good staff, nursing care, as well as the parents. So it is our responsibility to respond in neonatology with the knowledge, not only knowledge, but the skill and the compassion. Early recognition of the danger sign, stabilization, follow up, and family centric organization is our motto, because our goal is not to just the baby should survive. Our goal is survivor with a better life, that is to reduce the morbidity as far as possible. So with this, we have in this December, we have covered in Friday ka
Punch.
Pranch MAHAIP Kisan, where the topics of neonatology we thought it should be done at the end of the year, so that we'll be updated about the knowledge in neonatology from the all the experts from the different regions, 5 regions of the Maharashtra, and with the 2 experts, where they are going to tell, they are going to give a detailed means descriptions of the particular topic, and experts are giving the experts comments. So with this, let me welcome you all this on the MAHAIP platform. I welcome the today's uh, experts, Dr. Sandeep and Dr. Kiran sir, and today's presenters, all 5 presenters. But first, let me welcome the new team first. Today, we have our guest of honor is the President-elect 2026, Dr. Sanjeev Joshi sir, and President-elect Dr. Vinayak Patil, and our Secretary, Dr. Renu Boralkar ma'am, Vice President, Dr. Amul Pawar, and our scientific convener, Dr. Minha Sheikh sir, very well supported by Dr. Sachin, and the whole team of MAHAIP, including Sanjay, Rishi, Pankaj, and all the CIPBs who have joined for the today's program. I welcome you all on this MAHAIP platform, and I wish best wishes to all the presenters who are presenting the today's session: Dr. Ganesh, Dr. Biradar, Dr. Vipul, Dr. Avinash, and Dr. Harchal. So over to you, Sachin, and wish you a very happy New Year.
Thank you so much, sir,
Zero
for
to
your
six,
blessings and insights.
I wish all and the new team, they are going to do the great work in the next year, because they are very much experienced team, and definitely they are going to take a Maharashtra MAHAIP to the greater heights.
Thank you, sir. Now I request our Secretary of MAHAIP, Dr. Amol Pawar, sir, to welcome the
Thank you, Sachin.
delegates.
It has been a very nice journey. Captain is calling. Huh. It has been a very nice journey throughout in 2025, and this program, MAHAIP Friday Ka Punch, MAHAIP Ke Sang, was very much coordinated, very well coordinated by Dr. Sachin Patil. He has taken a lot of efforts along with Dr. Harshal, Dr. Rishi Lodaya, and whole scientific team under the guidance of Mina Sheikh sir. Actually, choosing these speakers from entire Maharashtra IIP or various districts of Maharashtra IIP is not a simple thing. He has to call many of the office bearers to take the speakers. Then he has to coordinate all the speakers along with experts, choose experts, and then to coordinate between experts and speakers so that a good scientific topic will be presented. So he has taken a lot of efforts. So kudos to him. And first of all, good evening, everyone. The new office bearer, Dr. Sanjeev Joshi, the past president, Dr. Sanjay Pakmude sir, then Dr. Renu ma'am, everyone, Amit Kakad is there, Dr. Praveen Gokhale sir is there, Sanjeev, then Vinayak Patil sir might be joining soon, Dr. Mahesh Iyer Rao, all the 5 speakers, Avinash, Vipul, Ganesh, then Padma Singh, and also Yangan, Harshal, and experts, both my dear friends, Dr. Kiran More sir and Dr. Sandeep Patil from Nanded. So next year, under the guidance of Sanjay Joshi sir, many of the programs will be continued. Dr. Sanjay Deshmukh sir is also there. So good evening, Sanjay sir. And already sir has elaborated many things about neonatology. So I request Sachin to move forward and to ask the dignitary to speak, and then we'll start the program.
Yeah.
Thank you.
Thank you so much, Amol sir. Now it's my pleasure to introduce our guest of honor, respected Dr. Sanju Joshi sir, President of MAHAIP 2026. Sir was chairperson of AOPN in 2024. Sir was EB Central IP 2025 and 2024. We all know that with Sir's vast experience and leadership, Sir will be shaping the future of pediatrics in Maharashtra. So now I request Sanju Joshi sir to speak. Joshi sir,
धन्यवाद सचिन.
please.
The President of Maharashtra IP 2025 Sanjay Pakmode, Secretary Dr. Amol, the entire team 2025. First of all, I take this opportunity to congratulate the team 2025 for your untiring efforts to take Maharashtra IP to another higher. You have really raised the bar for us. Definitely, it will be a big task to match your efforts which you have put in the year 2025. So, heartiest congratulations to the entire team. And this is my first appearance on this virtual platform, Maharashtra IP after the election. तो समस्त महाराष्ट्र आय टीच्या माझ्या रिस्पेक्टेड टीचर्स आणि सिनियर्स आणि माझ्या मित्रांना खूप खूप आभार, मनपूर्वक आभार. Whatever responsibility, whatever trust uh, you have shown in me and my team will put our 100% to match your expectations. Mitrano, nobody could have imagined that a person from a branch like Yavatmal could lead the Maharashtra IP few months before. But it is the power of democracy and the it is the power of democracy which we have adopted from this year onwards. That a person, common IITian like me, could be the choice of the people to lead the Maharashtra. So it will be a journey together, friends. It will be with the cooperation with each and every member. It will be with inclusivity of each and every Maharashtra IITian. I can promise that. So I think I will not go long way for today's discussion. I don't want to intervene between the wonderful science and the august audience on this virtual platform. I wish you all a very pleasant and a very prosperous year 2026. Again, congratulating Sanjay and Amol's team of 2025. I again congratulate my co-office bearer, Dr. Renu, Dr. Vinayak, Dr. Mahesh, for getting people's verdict in your favor and will be joining hands with me together to take Maharashtra IP to the pinnacle of excellence in the coming year. So thank you for this wonderful opportunity. Sachin and under the leadership of Mina, you were excellent, outstanding science you have given to the Maharashtra. So my best wishes to all the speakers and experts. Of course, I know the experts, they are masters in the field, Dr. Kiran and Dr. Sandeep. So thank you all for this wonderful opportunity. So let us move forward in the journey of Maharashtra. Thank you all.
Thank you, sir, for your blessings. Uh, our next guest of honor is respected Dr. Vinayak Patil, sir, President-elect MAHAIP 2026. Sir is the director of Kilbil Children's Hospital, Alibag. Sir was the vice president of MAHAIP. Uh, Sir, with his remarkable contribution to the pediatrics, definitely, sir is a true leader in our field. Let's welcome, sir. Over to you, Vinayak sir.
Yeah. First of all, thank you, Sachin. And it's an honor to be the guest of honor at this MAHAIP Friday Punch. Actually, I was in one of the functions which got little lengthened. It's a school gathering, and which got little lengthened. That's why I'm in the car traveling. But still, it's an honor to be president-elect for this function. As Sir told, Sanjeev Joshi told, Sir told, from coming from a small branch of Yavatmal, our Raigad branch is also a very small branch. And it's a power of democracy that a small branch from Raigad, I am the second president of MAHAIP, which is all due to the all the pediatricians of whole Maharashtra. I am elected unopposed. And as the elections are over, now I think we should uh, forget all the elections and all those things. We should be united as a Maharashtra IAP pediatricians in each and every aspect, basically. And MAHAIP have done a great work in past, basically in this year also in 2025 under the leadership of Sanjay Pakmodekar and Amal Pawar and all the team. They have worked excellently uh, and taken the MAHAIP to a greater height. And I am hopeful and confident that under the leadership of Dr. Sanjeev Joshi sir also will continue to be shining in academics and other activities, which will be helpful whenever during my tenure when I take over the reins of MAHAIP. Of course, once again, thanks for inviting me as the guest of honor for this today function. And my utmost request is that whole Maharashtra should be united in each and every aspect, in every field. Whenever there is, there may be anything it may be. Now forget the elections, forget the differences. We are all united. There are no personal anything with anyone. It's just a democracy. When the great leader, the politicians can come together, we are a very minute things, and we should be together and in each and every aspect, so that we shine on the like central IIP Maharashtra. We should be always ahead in all aspect. Thank you again, Sachin and MAHAIP for giving me this honor. Thank you.
Thank you, sir, for your blessings and insights. Now, for further proceeding, I request Dr. Rishi sir to start the further proceedings. Dr. Rishi sir, over to you.
सचिन रेणू मॅडम
Rishi sir,
जॉईन झाले?
unmute.
रेणू मॅडम जॉईन झाले?
हो, परत rejoin.
Renu madam is there. She is there.
हा
I can see her.
थँक्यू सचिन बोला ना सर.
ऋषी रेणू मॅडमला दोन मिनिटं बोलू द्या.
हो 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 रेणू मॅडम.
Yes, yes. Good evening all. शुभ सायंकाळ. सगळ्यांनीच आतापर्यंत सांगितलेलं आहे. आय एम व्हेरी हॅपी टू बी द पार्ट ऑफ द टीम 2026-27 as a secretary of MAHAIP. And thanks to all my Maharashtra IIP friends who gave me the opportunity to serve our branch, our state. And I congratulate and also applaud to the 2025 team of Dr. Sanjay Pakmode, Dr. Amol, Dr. Minaz, and Dr. Sanjay, all the other delegate OBs, EBs, and CIP EBs also, who have excellently done the programs scientific way and also have achieved very high height, so that the next year it is again a challenge for the next incoming president to make it to other new height. So without wasting any time, as the other delegates are waiting or the speakers are waiting, I will like to congratulate them that they have come on this platform and also wish them best. And also hello to the Dr. Sandeep and Dr. Kiran sir. Over to you, Rishi.
Yeah, thank you, madam. After hearing all the president and secretary of MAHAIP, now I just request MAHAIP convener Dr. Sanjay to address the online delegates.
Good evening, all respected MAHAIP members. It is a mixed feeling for me as a convener for MAHAIP this year. We are towards the ends of this excellent academic year under the leadership of Dr. Meena Sheikh and scientific committee. And Friday Ka Punch was only able to deliver because of the efforts of Dr. Sachin Patil. Since last 12 months, every month, we are coming with Friday Ka Punch with all super specialties. So it's a team efforts, and I hope Dr. Sanjeev sir is here. So they will continue the programs in the next year also in their action plan. And it is a great thing. We are united together. Academy is first. And my best wishes to new body under leadership of Dr. Joshi sir, Dr. Vinayak, Dr. Amol. And this year, I am very thankful to all peoples. Every activity, women's wings, all EBs, they done excellent job. So we are very happy. And today we are coming with a new session. So my best wishes to all the faculties and all experts, Dr. Kiran Mode sir, Dr. Patil sir. And I hope this Friday Cup punch will continue next year in the same name. So thank you and welcome to the academics.
Yeah, thank you, Sanjay, for guiding us. Now I invite Dr. Meenakshi sir, who is the scientific convener for MAHAIP, to address the session.
Good evening, all. Thank you, Rishi, for this opportunity. At the outset, let me thank the entire Maharashtra IP 2025, led by our own Dr. Sanjay Patmode, President, Dr. Amol Pawar, Secretary, Dr. Deshmukh, our convener, the entire team who has given responsibility to us. And we did try our best to put up the better show that we can do. Uh, uh, what we say that it was a great team effort, and as a scientific convener, whatever success has been there, it is the entire team, and any if shortcoming is there, I owe to that shortcoming as a scientific convener. However, the great year altogether, we could get lot many good new speakers. They have delivered great, and the new team is very solid under the leadership of our own Dr. Sanjay Joshi, Dr. Patil, Renu Madam, and all. So all the best for the incoming team. So also one and all thanks to our experts, including today our own friends Dr. More sir and Dr. Sandeep and all faculties. Thanks a lot. Over to my friend Rishi.
Yeah, thank you, Meenakshi sir. Now, after hearing all our this, let's start for today's topic. It is the neonatology in pediatric office practice, for which we have two main experts here and five speakers here. In the experts, we have Dr. Kiran More sir from Thane. He is MD FRACP from Australia, FRACMA from Sydney, GCSSR from Harvard University, and T. Nico from Canada, and ECMO diploma in France. He is a neonatal senior consultant and HOD funder and director of Little Fun NICU Mumbai. Second expert we have. Hello. Second expert we have Dr. Sandeep Patil from Nanded. He is DM Neonatology and MD Pediatrics Fellow in PICU, Director of Care Advanced Pediatric and Newborn Center, Nanded. Then other from this we have five eminent speakers from different parts of the Maharashtra. Out of that, first one, I invite Dr. Ganesh Bhatkar sir from Akola, who will be speaking on Golden Hour, What's New. He is a DM Neonatology, MD Pediatrics, Assistant Professor, GMC Super Specialty Hospital, Akola. Second, our speaker is Dr. Padmasinha Birajdar sir from Latur. He will be speaking on neosepsis protocol. He is a consultant pediatrician from Latur. Then Dr. Vipul Patil sir from Raigad. He will be speaking on neoglucose check. He is a consultant pediatrician and neonatologist from Sahil Child Care Hospital, New Panvel, Raigad. Then fourth speaker is Dr. Avinash Bhosle sir from Jalgaon. He will be speaking on high-risk heroes monitoring protocol. He is a developmental pediatrician from Sri Chaitanya Hospital, Jalgaon. And last speaker, Dr. Harshal Wagh sir from Sangli. He will be speaking on neonatal window, focus for neonates. He is MD Pediatrics, Assistant Professor, GMC Miraj. Thank you. So over to Dr. Sachin Patil.
Yeah, thank you, sir. Now we will start the session. I request Dr. Ganesh sir, please start the session.
Hello, sir. My screen is visible and I am audible.
Yes, sir. Yes, sir.
Yes, yes.
Yes.
Yes, sir. Thank you, sir. A very good evening to all of you, and thank you, MAHAIP, to give me opportunity for presentation. Today we will discuss golden hour management. What new according to the latest ninth edition, which is published in 22nd October 2025. And the ninth edition changes must be incorporated by June 1st, 2026, so that we have to work with our institution to develop an implementation plan for a smooth transition. We know the 8th edition, and there are some changes with respect to 8th edition that we will discuss step by steps. So the first change is the change that birth and the initiate cord management. At the time of the birth, we have to initiate a cord management. For example, if the baby cried immediately after birth, what I have to do? If not cried immediately after birth, what I have to do? That I have to decide. The second change with respect to deferred cord clamping or a delay cord clamping. Previously, it is at least 30 to 60 seconds, but as per a latest guideline, it should be at least 60 seconds. The next change is with respect to the umbilical cord milking. The previously that for newborn less than 28-week gestation, umbilical cord milking is not recommended because it is associated with increased risk of intraventricular hemorrhage. That point is going to remain same, but there is some addition with respect to that. For newborn infant 35 to 42 week of gestation who is a non-vigorous despite stimulation, then umbilical cord milking may be a reasonable alternative for that. And for babies with respect to 28 to 35 week of gestation and non-vigorous baby, there is a not enough evidence recommended routinely. And the point that less than 32 week of gestation, that umbilical cord milking is contraindicated. The next change is they have removed the suction term from the initial step of management. Previously, there is a warm, dry, stimulate, position, airway, suction if needed. And as per latest, there is a warm, maintain normal temperature, dry, position, stimulate, and clear airway if needed. Clear airway means if there is a visible secretion, then we can take a sterile cotton or a sterile gauze and just wipe off the mouth, or if suction if needed. The next change is with respect to terminology. Previously, there is a term used for positive pressure ventilation, which is replaced by the term of ventilation, because the term ventilation emphasizes the goal of airway entry and the lung aeration, not just the act of giving positive pressure ventilation. So, and it is also simplify communication that all effort aim to ensure that the baby is being ventilated regardless of the device use. The next change with respect to target oxygen saturation, previously started at 1 minute of target oxygen saturation of 60 to 65%. But the pulse oximeter often takes 20 to 30 seconds or more to pick up the stable signal after birth. And the 1 minute saturation value is therefore inaccurate and inconsistent. Therefore, the changes has been made and the target oxygen saturation started with a 2 minute, that is 65 to 70%. The next change is with respect to oxygen concentration. That also has been changed. For less than 32 week of gestation, start with a oxygen of 30 or more than 30%. For 32 to 34 week, start with 21 to 30% of oxygen. For 35 or more than 35 weeks, start with the 21% of the oxygen initial setting. The next change is with respect to initial peak inflation pressure. Previously, it is a 20 to 25 centimeter of water. Now they have changed with respect to gestation. If it is a less than 32 weeks, start with 20 to 25 centimeter of water. If it is a 32 or more than 32 week of gestation, start with a 25 to 30 centimeter of water. The next change is with respect to ventilation rate. Previously, it is a 40 to 60 breath per minute, and now it has been changed to 30 to 60 breath per minute. And because this range is a best mimic with a natural newborn respiration, achieves effective ventilation and heart rate rise, minimize air trapping. Moreover, during chest compression, the ventilation rate is 30 per minute. The next change is with respect to ventilation corrective steps. Previously, if the heart rate is not increasing within 15 to 30 seconds of ventilation and you don't observe any chest movement, start the ventilation corrective steps, that is MR SOPA. Now the changes is like based on your initial assessment, infant and clinical situation, you may choose the steps that is most likely to helpful and prioritize the order in which you perform them, so that you can rearrange the MR SOPA and what is the best based on your assessment you can do. That change has been made. The next change is with respect to laryngeal mass airway, a primary device. If the baby cannot be successfully ventilated with a face mask and intubation is unfeasible or unsuccessful, a laryngeal mask may provide a successful rescue airway. In most cases, ventilation with a face mask or a laryngeal mask airway can be helpful. The next change with respect to endotracheal tube size. Previously, it is a less than 1 to 2, and it's a more than 2. Now they have made a little changes. If the baby weight is a less than 1.2, go for a tube size of 2.5. 2 millimeter tube is an optional one. With the weight is a 1.2 to 2.2, the tube size is a 3. And if it is a weight is a more than 2.2, then the tube size is a 3.5 we have to use. And now the endotracheal tube depth. Previously it from tip to lip. Now it has been changed to tip to gum. We have to calculate the depth by NTL, that is a nasal tragus length plus 1, that come in a centimeter. We will, for example, it come like a 9 centimeter. We will insert the endotracheal tube so that the marking on the tube corresponding to the estimated insertion depth is adjacent to the anterior edge of the baby's upper maxillary gum in the midline, as shown in the diagram. Because the gum is the fixed skeletal landmark and the lip position is variable, so that the change has been made. This is the same what we have discussed, what are the changes in the 9th edition. This is beautifully done by Dr. Satyam, and all changes are there in a single diagram. Thank you very much.
Thank you, Ganesh sir. Now I request Dr. Kiran More sir to give some experts comments.
Yeah, I think very nicely summarized by Ganesh and very clear-cut messages. I mean, these are subtle differences are there and very practical changes which have come up, like, timing the saturations. And I think delayed cord clamping is something really one should practice. And that's a good practice change, I think should happen at ground level and with conjunction with obstetricians. And definitely no cord milking, because that is especially for the babies who are extremely preterm. So wherever possible, we should always try to wait, and that's where we lose that 1 minute or initial 60 seconds also. So I think the whole resuscitation also is aligning much with that. That you can wait for 1 minute, you start recording even saturation after second minute, and use of ECG leads also, checking heart rate. That is, I mean, that has been there from the previous thing also. These are the practical things people should apply, because a lot of mishaps will happen whenever the detection of the heart rate, detection of the saturations, and the timings, all those things. LMA is not available in many places, but I think one should start keeping neonatal LMAs, because many times appropriate mask size are not there, and people, if they don't intubate, then resuscitation becomes difficult. So I think LMA one should definitely practice. So more or less, I mean, rest all are fine. I mean, those timing rates differences and all are very subtle things. But uh, yeah, I think people should do more simulations for NRPs, and practice with the newer steps with your team, with your doctors and nurses. One should do some regular simulations for practicing steps of NRP, and that's probably the way forward. So well done, Ganesh. Very crisply done. Yeah.
Thank you, Kiran sir. Sandeep sir, do you want to add anything else? Sir, unmute sir, please.
Unmute, Sandeep.
Sorry, I'm audible now?
Yes, sir.
Ganesh, you have very well covered, and they are up to the mark, and very crystal clear. You have mentioned the differences in tabulated form, and Kiran also you have added lot many things. Only one thing I want to add. They have added one thing of teaching intubation in teaching institute by using video laryngoscope. It has increased very high chances of intubation in early phases. So it can be considered. So lot other things completely he has covered. Very well done, Ganesh.
Yeah.
Thank you.
Yeah, and
Thank you,
there are some
Sandeep sir.
cheaper, there are some cheaper video laryngoscopes are available in the market now. Previously, they used to be very expensive, but now you can see they're on the internet also they are available. So one can actually just need it, especially in teaching institutes. So very valid point, Sandeep. We have also tried instituting that.
Thank you all. Now we will start with the next session. I request Dr. Padmasree Birajdar sir to start the session. That is the neosepsis protocol. Uh, Over to you, Padmasree. Hello, Padmasree
Am
sir.
I am I
Yes,
am I
yes,
audible?
yes,
Yeah,
yes. Right now you are
thank you,
audible.
MAHAIP, giving this opportunity for presentation. The operator, please, next slide. Yeah. So neonatal sepsis, as we know that this is one of the most common scenario which we are facing in our day-to-day practice, and one need to have very high index of suspicion to suspect a sepsis in newborn. This topic is very much important for a common pediatrician as almost 28% of the newborns die due to sepsis in our country. So when we suspect sepsis in a scenario is when there is temperature instability, lethargy, poor cry, baby is not having good suck, poor perfusion, prolonged capillary refill time, babies having feed intolerance or diet hyperbole. We can see scleroderma or hypotonia, bradycardia, tachycardia, distress, apnea, and gasping respiration also in case of neonatal sepsis. Next. Any sudden increase in ventilator requirement in case of ventilated babies or hypoglycemia or changes in sugar levels, metabolic acidosis, or there is a heart rate variability with transient deceleration is suggestive of clinical sepsis. Next. So fungal sepsis, we should have suspicion about fungal sepsis in a scenario where we are dealing with ELBW or preterm gestational babies having persistent thrombocytopenia or unexplained hyperglycemia. Along with that, those who are being treated with cephalosporins for more than 7 days or prolonged ICU stay or requiring TPN, prolonged intubations or lines in situ, or we are giving steroids. These are the scenarios where fungal sepsis should be suspected. Next. We classify sepsis as early onset and late onset depending upon the hours of gestation when it presents to us. Usually, early onset sepsis is maternal in origin and presents with pneumonia and respiratory distress. The common organisms involved are E. coli, Klebsiella, Staphylococcus aureus. The risk factors associated with early onset sepsis are prematurity, low birth weight, maternal chorioamnitis, prolonged rupture of membranes, Apgars less than 6 or asphyxia, maternal UTI, unclean vaginal examinations, or prolonged labor and meconium stained amniotic fluid. Next. Late onset sepsis is the sepsis which we see after 72 hours of life. The common organisms are Coagulase negative Staphylococcus aureus and Klebsiella or Staph aureus. The risks include our low birth weight, prematurity, admission in NICU or mechanical ventilation, invasive procedures, parenteral fluids, or TPN. Next. The community acquired late onset sepsis is mainly due to poor hand hygiene, poor cord care, or bottle feeding or prelactal feeds. Next. The investigations which we routinely do to diagnose sepsis is blood culture sensitivity, CBC, which we commonly do, C reactive protein, CSF, and urine cultures. Next. So this table will give us the more clear idea. As we know, blood culture is the most important and the gold standard one. We should give 1 ml of sample in each bottle. The growth after 72 hours of uh, taking samples will give us idea about the organism. Usually, the growth is seen at before 48 hours, but by 72 hours it will be confirmed one. CBC we usually send in which we see for absolute neutrophil count and immature to total leukocyte count. ANC, which is highly sensitive and less specific, and all both these investigation ANC and IT ratio should be performed after 6 to 12 hours of life. Another investigation which we most commonly do is CRP. CRP more than 10 milligram per liter is suggestive of sepsis. Again, it's highly sensitive and less specific. Should be done after 12 hours of life. CRP, serial CRP will be of more value to us rather than a single digit. CSF analysis and culture, in which we see proteins and sugars. In case of term baby, more than 20 cells per microliter, and in case of preterm baby, more than 25 cells per microliter. And proteins more than 100 in term, more than 170 in preterm, will give us idea about sepsis. In case of sugar in CSF sugar, less than 40 in term baby and less than 20 in preterm baby will give us idea about meningitis or sepsis, or CSF blood sugar ratio less than 0.5. So CSF should be performed in all symptomatic neonates before starting antibiotics, and in suspected early onset sepsis, and in all cases of suspected late onset sepsis. Next. The practical screen, which is of more useful for common pediatrician, is leukopenia. There is count less than 5,000 per mm cube, or neutropenia as per the Monroe's curve, or IT ratio more than zero point 0.2, and micro ESR more than 15 mm at 1 hour of life. Serial normal CRP has a good negative predictive value to rule out sepsis. So CRP is more useful for ruling out sepsis than diagnosing sepsis. The diagnosis is usually by blood culture. So more than about two positive tests will be suggestive of neonatal sepsis. Next. So CSF fluid analysis. When to perform CSF in early onset sepsis? When we get a blood culture positive sepsis or a symptomatic neonate with positive lab evidence of sepsis. Infants who worsen despite of initial antibiotics. In all cases of late onset sepsis, except critically ill, these are the scenarios where we are supposed to perform CSF. Next. The CSF parameter in sepsis, the cell count more than 20 microliter in case of term, and in more than 25 in case of preterm, where more than 60% of polymorphs, glucose less than 40 milligram in term and less than 20 in preterm, CSF glucose ratio less than 50% or 0.5 says of sepsis. The CSF sample has to be processed before 2 hours, otherwise the sugars will drop. Proteins in CSF more than 100 in term and more than 170 in preterm is suggestive of meningitis. CSF protein is the most sensitive indicator to rule out sepsis, and CSF culture will be definitive diagnostics. Next. The other tests which are done are chest X-ray and urine culture. Next. So the management is the supportive management, in which we are supposed to treat the newborns in thermoneutral environment, maintain the saturation in normal range, treat anemia, thrombocytopenia, or DIC with component therapy, regular blood sugar monitoring, monitoring of hemodynamics, and good nutritional support is the backbone of the treatment. Next. The specific treatment in which blood culture, in case of symptomatic neonates, blood culture at birth, CBC and CRP at 6 to 12 hours life, CSF examination, and urine culture if febrile or there is evidence of direct jaundice. Next. So, in case of asymptomatic at risk neonates, depending upon the scenario, if we have less than 37-week plus chorioamnitis or PROM more than 18 hours of life, we should have sent the blood culture in at the birth along with CBC CRP at 6 to 12 hours of life. And this chart will give us the more idea when we should start the empirical antibiotics. And in scenarios where we have babies with gestation age more than 37 weeks with premature rupture of membranes or more than two risk factors. So you are supposed to send CBC along with CRP at 6 to 12 hours of life. No antibiotics are advised. Just observe, and if labs are normal and baby is well, discharge the baby by 48 hours. And if labs are abnormal and culture is negative, baby is well, then you send the blood culture and if culture is positive, then treat with antibiotics. Depending upon, so by this chart, if we get a CSF sterile and labs are normal and baby is well, you stop antibiotic. If we get a CSF sterile, sorry, culture sterile and labs are normal, baby is well, continue antibiotics if mother has received the antibiotic. In another scenario where we are getting culture positive, we continue antibiotic and do the lumbar puncture. So we'll get the idea how to treat and for what duration from this table. Next, the choice of antibiotic, as we know, the first line antibiotic usually are MP and Genta, but now the resistance is so rampant in NICU, though hardly we get any sensitive bacteria to all these first line antibiotic. In case of suspected meningitis, add cefotaxime. In case of community acquired or hospital acquired infections, ampigenta or cloxamicin along with cefotaxime will work. In case of third line and resistant infections, Mero plus Vanco is advised. Next. In case of fungal sepsis, the antifungal of choice is amphotericin B, and for prophylaxis purpose, fluconazole is used commonly. Next one. So when to change the antibiotics in culture negative sepsis, definitely not before 48 hours, and in case of culture positive sepsis, according to the sensitivity report. Next one. So duration of antibiotic in case of sepsis, where culture positive and no meningitis, to 10 to 14 days of antibiotic is supposed to be given. In case of sepsis with meningitis, 21 days of antibiotic is required. In culture negative but suspected early or late onset sepsis, where baby is improving but still symptomatic or initial CRP is positive, then again antibiotics are given. If two CRP values 24 hours apart are negative, then we can stop the antibiotic. If the CRP values are positive, then 7 to 10 days of antibiotics are needed. So minimum meningitis 21 days, culture positive sepsis 10 to 14 days, and culture negative symptomatic babies 7 to 10 days of antibiotics is advised. Next one. The adjunctive therapies which are usually discussed are double volume exchange or immunoglobulins or granulocyte colony stimulating factor, but none of these have been recommended by the books or journals or evidence. Next one. To summarize, so a very high degree of suspicion is very much required for all practicing pediatricians. Depending upon the presentation, we classify it as early onset sepsis or late onset sepsis. Usually in developing countries, the bacteria causing both early and late onset sepsis, the bacteria are common for both the scenarios. Blood culture is the diagnostic modality for sepsis. Sepsis screen is to rule out sepsis and not to diagnose sepsis. In symptomatic neonates, we must send blood culture. Lumbar puncture is required in all culture positive sepsis, late onset sepsis, or symptomatic early onset sepsis. First line therapy is ampigenta. Resistant strains, if we have, then cloxacillin and amikacin. In case of suspected meningitis, add cefotaxime. And in severe resistant cases, Mero plus Vanco is the modality of treatment. Duration, as we discussed, meningitis should be treated 21 days, culture positive sepsis for 14 days, and in case of suspicion sepsis, 7 to 10 days of antibiotic is very much required. Thank you.
Yeah, thank you, sir. Now I request Dr. Sandeep, sir. Do you want to add anything, especially on procalcitonin?
Yeah. So procalcitonin, we will discuss it later, but few
Okay.
things I want to add. First thing is, see, early onset and late onset sepsis, very simple approach we should follow, which investigations to be done and what we have to do. This all sepsis screen and blood culture, these things are there. But for early onset sepsis, you're not going to do sepsis screen except blood culture because sepsis screen is going to be very falsely positive. You are going to do sepsis screen in late onset sepsis. In late onset sepsis, it is to rule out sepsis, not rule in sepsis. This you have to make it clear. For then what for early onset sepsis we have to do? Early onset sepsis, we have a lot of scoring systems. So sepsis scoring systems, we do that, and according to that, we consider for starting empirical antibiotic, and we dare to stop IV antibiotics as blood culture comes sterile. So we should have that much of clarity while using these substances. Another point, as sir has raised about procalcitonin. Procalcitonin is definitely sensitive and more specific as compared to CRP, but the differences are little. But for early onset sepsis, you can consider PCT as superior to CRP. But for initial 72 hours, we usually don't consider for this acute phase reactant to be considered for ruling in sepsis. So it is always better to follow sepsis screen total scoring systems for giving empirical antimicrobials and dare to stop IV antimicrobials as and if you get sterile culture. That's all from my side. Kiran, you want
Thank you,
to add?
Sandeep sir. Kiran sir, do you want to add anything else? Sir, please unmute.
Unmute, Kiran,
Yeah,
unmute.
yeah. So very well said, Sandeep, and very nice presentation, Dr. Biraj there.
Thank you.
See, sepsis is a major sort of game changer for Indian practice in neonatology. You know, we all are scared of sepsis, and it is changing the outcome. So I think that focus should be on prevention of sepsis. We have not spoken about prevention of sepsis, and that itself is a big topic. Also, secondly, as Sandeep said, you know, we should be bold not to start certain babies on antibiotics, who are like preterm but clear-cut RDS and no evidence of sepsis. We should be bold to stop antibiotics, as Sandeep said, after 48 hours or 72 hours if markers are negative, culture is negative. Um, and yes, no role in CRP actually beyond 6 hours. We do sometimes still do, but I think sepsis prediction score easily available on the internet. You can see if there are high risk, definitely don't take chance. But if there are no risk factors, one should be really bold enough. And we have, in fact, babies who are ventilated also. Sometimes we have not started antibiotics because clear cut RDS. Secondly, early onset sepsis drug of choice. So we had discussion in the Mumbai group also other day. Dr. Minaz must have read those discussions. So when I was heading Vadia, there also we started MP Genta. So I'm not saying like so your decision for first line or second line should be based on the antibiogram. We should actually regularly study all the culture positives in early onset and late onset for the prior 3 months or 6 months, and then come up with a plan what suits best for your unit. And interestingly, MP and Genta were not actually exposed. So we did switch to MP Genta even in Vadia, busy unit like 130 bed, both sides, both inborns and outborn, we switched MP Genta. If the babies have come on day one, we had started that as a first line. And we in fact had a quite good positive response. We stayed for MP Genta for a period of a year, 2 years till I was there. Even in the MRN hospital and my current place, we still follow MP Genta. So you will be surprised that in fact many centers you don't find MP because there is no demand for MP. So the bacteria are not exposed to MP, and it is actually giving good results. So something worth considering. But obviously, if you're an outbound unit and you're getting babies who are sick, then you have to change the policy as per your antibiogram. Again, second line, third line, based on the bugs and the bugs which you are coming in your unit. Or sometimes you also get a pattern of certain bugs in the referral units. So I think you have to be very watchful. So you need to have a very good microbiologist who's behind you to support with all this data. Procalcitonin, I think Sandeep said, but I think CRP is considered as, probably positive CRP is more important than the negative. Sometimes the premature babies don't mount CRP response, or sometimes there could be false CRP positive also. So CRP is not very accurate. If you want to rule out sepsis, probably then procalcitonin has got more negative predictive value than the positive predictive value. So if you are confused, sometime CRP is borderline elevated, 15, 20, and you want to stop antibiotics, maybe doing procalcitonin and ruling out sepsis might be very useful thing. And last but not least thing, yes, have a high index of suspicion. So which actually very highlighted nicely by the speaker, that anything changes, like something not quite right. If you get that sixth sense, baby is behaving differently, have a sepsis screen to rule out that. And in fact, one more practice which we see is that we follow a lot of family-centered care. So we allow mothers to come in quite regularly. Mothers are the even better detector. They will tell you that my baby is behaving differently today. It's not looking good. I will do a sepsis screen. So those mothers, in fact, and some of the trained nurses are very good in picking up. And there are like sepsis hero scores are there. Like heart rate variability is also very important criteria. We don't need hero monitors, but we need a good trend of heart rate variability. And heart rate variability can actually tell you on the rounds if the baby is going into something, like going into early sepsis. So early prediction is very important because sometimes the babies don't give you time. Within 6 to 12 hours, we lose the baby and whole battle is lost. So I think those are the things, and rest all was very nicely covered. So that's from my side.
Yeah. Thank you, Kiran sir. Now we will move towards the third session by Dr. Vipul Patil on the neo glucocheck. So I request Dr. Vipul, please start the session.
Yeah. Good evening, everyone. Thank you, MAHAIP, for giving this platform for presenting me on the neonatal glucose monitoring.
Vipul, make it full screen.
Yeah,
Make it,
just
yeah.
yeah. So as everyone knows that it is one of the most common metabolic problem in the neonates, which we always deal with, and there are reasons for it. So first and foremost important is when the cord is cut, there is a disruption in the supply of the glucose from the placental end, and most glucose supply is dependent on the glycogenolysis in the first phase, because the mechanisms for gluconeogenesis take around 8 to 12 hours for generating the glucose. So by that time, and second is because there are counter regulatory hormones, or there is a immaturity of the counter regulatory hormones, so less of glucagon. Sometimes because of the maternal condition, there is a hyperinsulinism which prevents that baby to go from anabolic to a catabolic state, and that's why there is a transient hypoglycemia in the neonatal period. So as everyone knows, can we define hypoglycemia? It is very controversial and there is lack of consistency at present, as many times it happens that on that glucose level, there some babies are not even symptomatic, and there are some babies who have a good, means the sugar levels are borderline, but still they have a lot of symptoms and signs. So they have defined the operational thresholds for late preterm especially, and the term babies who are at a very high risk of getting hypoglycemia. So for symptomatic, the blood sugar level less than 40. For asymptomatic neonates, for first 4 hours, the cutoff is 25. 4 to 24 hours, it is 35. Within first 24, 48 hours, 47, 45. And more than 48 hours, it is 60. So there is still positive on the literature for premature neonates who are less than 34 weeks, and where there is still, we advise to maintain a blood glucose level of at least 50 milligram per deciliter. So what are the risk factors for babies to get a hypoglycemia? So there are maternal risk factors and a neonatal risk factors. Maternal risk factors are maternal diabetes, whether it is a gestational or a pre-gestational. Certain drugs like beta blockers, terbutaline, if there is excessive dextrose administration during intrapartum period, maternal hypertension or pH, and neonatal risk factors, prematurity, less than prematurity, hypoxia, ischemia, babies who are born IUGR, large for gestational age babies or small for gestational age babies, sepsis, hypothermia, polycythemia, and some syndromic features like Beckwith-Maidman and all. So these are the risk factors, and so these babies should be monitored. Now, what are the signs of hypoglycemia? So signs are divided into two things. One are autonomic and one are neuroglycopenic. So autonomic signs are, there is sweating, pallor, tachycardia, tachypnea, tremor, and jitteriness. And in a neuroglycopenic, when the brain is not getting glucose, hypotonia, lethargy, seizures, weak sucking, and a abnormal cry, either a weak cry or a high-pitched cry. Or what is the screening schedule? So when these babies who are the high-risk babies should be screened. So with the babies who are at a high risk, all neonates which are having these high risk factors at 2 hours, 6 hours, 12 hours, 24 hours, 48 hours, and 72 hours. Sick infants, especially which are ventilated or sepsis, every 6 to 8 hours. Stable, very low birth weight infants and the babies who are on TPN, initial 72 hours, every 6 to 8 hours. After 72 hours, at least once or twice a day. Infants who are born to diabetic mothers at 1 hour, 2 hour, 3 hour, 6 hour, 12 hour, 24 hour, 48 hours. And the babies undergoing exchange transfusion 1 hour after exchange, we should definitely screen for the glucose. As everyone knows that the hypoglycemic brain injury is more detrimental even than a birth asphyxia. So these babies should be screened well in time. We need to prevent the hypoglycemia. Even if the babies are asymptomatic, we need to treat them promptly. As the threshold is kept less, many of the times even the asymptomatic babies are being asymptomatic babies are being over treated for the hypoglycemia, but still that is acceptable because the neurological and developmental outcomes are very poor once we get a hypoglycemic brain injury. So key takeaways of my presentation: first is the most common metabolic disorder. We should be having a high index of suspicion, and we should definitely screen all the babies who are at high risk. But as there are protocols set, so every time all the high risk babies are usually screened everywhere. It is very rare that we miss the hypoglycemia in a neonate. And the prompt treatment. So prompt treatment in terms of IV glucose administration and proper monitoring of the neonates during for feeding and everything in a risk babies is needed. Thank you. Thank you so much.
Thank you, Vipul, for a crisp and crystal clear presentation. Now I request Dr. Kiran sir. Do you want to add anything else?
No, I think he said most of the thing. I think we should be very much mindful and responsible that it is criminal to allow baby to go into hypoglycemia if the baby is in the ICU. So we should be again focusing on the prevention, and as Vipul highlighted, identifying those high risk babies and having a that screening protocol as he listed is very important. And I see lot of this such a simple thing. Babies used to come to us referred with hypoglycemic brain injuries just because the baby get diagnosed only when the seizures occurred, secondary to hypoglycemia. But then when the seizures occurred, as again Vipul highlighted, it is a serious brain injury, as equivalent to even asphyxia. So I think prevention is important. And this transient hyperinsulinemia baby groups of babies are very notorious, infant of diabetic mother or so severe IUGR babies, or sometime with this pancreatic hyperplasia babies, they are the notorious ones where, they needs to be very carefully monitored and they are difficult ones to manage for hypoglycemia. So yeah, I think very nicely covered.
Yeah, thank you, Kiran sir. Sandeep sir,
Just
your
one
take home.
thing to add, just this asymptomatic hypoglycemia carries lot of poor neurological outcome. So you should identify high risk neonates like IUGR babies and infant of diabetic mothers. The monitoring of them should be done and should be addressed very clearly. Don't let the baby to have symptoms and then treat.
Yeah.
So from monitoring point of view, these points are very important.
Yeah, thank you, Sandeep sir. Very useful tips. Monitoring, monitoring, and monitoring. Thank you, sir. Now I hand over the mic to my co-moderator, Dr. Rishi sir, for further proceedings. Dr. Rishi sir, over to you.
Please unmute, sir.
Unmute. Sir.
Thank you, Sachin.
Yeah.
So we will go proceed further. I will invite Dr. Avinash Bhosle sir from Jalgaon to speak on his topic on high risk heroes monitoring the protocol. Over to you, sir.
Yes, sir. Am I audible and visible?
Yeah, make it, yeah, fine.
Yeah, so a very good evening to all of you. And I'm first of all, I'm very thankful for MAHAIP for giving me opportunity to talk in today's Friday Ka Punch. And I'm very in depth with our experts, Dr. Kiran More sir and Dr. Sandeep Patil sir, for guiding with us. And very much in depth with Dr. Sachin Patil for taking this initiative for 11 months altogether and taking all the pains, and Dr. Rishi sir. So my topic is high-risk heroes monitoring protocol. We'll try to quickly cover the things. So what the evidence is, so across the globe, various studies has been done. So whatever the methodologies has been applied. So when it comes to the long-term outcome with this high-risk neonates, there is as low as 20 to 20% of my moderate to severe, up to 40 to 50% of moderate to severe neurodevelopmental impairments in this cohort of neonates. So definitely it gives the it highlights the how much it is important when to take care of these kids in a structured way when it comes to the intact survival. So first doing this is the stratifying the newborn in an appropriate age group before discharge of the baby. So if you say the NNF guidelines, even the IAP has given the guidelines accordingly, which we can classify them in mild, moderate, and severe categories. It is mainly designed with the clinical criterias. Of course, there are the social issues also, like maternal depression and family issues, discordant families, and that also leads to the child into the high risk category. For as far as this conservation is concerned, the clinical part is covered. And why it is important? Because according to the group which the child neonate falls, mild, moderate, severe, the support is required, and the type of intervention and the setup where it can be dealt, it is need to be dealt is seen. So the first step we saw the stratifying. After that, it starts with communicating with the families of the high risk neonates. So it has been said that the every healthcare worker should be formally trained. He should do in a structured way. One-to-one counseling should be done, and a designated area should be there for the counseling preferences, and family support groups or peer-to-peer support groups should be encouraged. So it's high time that we get trained for ourselves in that way. There are many protocols are there, but still key to effective communication is to listen, observe, verify, express the, and then express the things. So coming to the screening with the medical things, thyroid screening is advised at around 14 to 72 hours of the age. Of child unstable, so it can be delayed up to 7 days. And in case of VLBWs and NICU babies, it need to be repeated at the 2 to 4 weeks of the life. For hearing protocol, we need to screen the child by neonate by 1 month, diagnose it by 2 months, and intervention should start with the 3 months. Universal screening via OE screen is ideal. All NICU babies should undergo the ABR testing. In growth monitoring, it closely mirrors how the child nutrition is there, and nutrition is altogether a separate topic, but the mother milk with appropriate fortification has to be, and supplementation has to be encouraged, and monitoring the growth of the infant with each health or immunization visit with appropriate growth chart should be done. Need to be continued with at least 6 years of the age. And once preterm reaches up to 40 weeks of corrected gestational age, further growth can be monitored on WHO growth charts. And consider after going to the 40 weeks of corrected gestational age, that can be considered as a that is considered as a day one with WHO growth charts, which are there with our regular files, and we can follow with them. For the ROP screening, definitely less than 2 kg and less than 34 weeker need to be screened. And again, it has to be first screen has to be at the 4 weeks of the 4 weeks of the life, and it can be done at earlier at 2 to 3 weeks if the baby is less than 28 weeker or less than 1.2 kg. Frequency, it has to be repeated after 2 weeks, and the goal is to see the complete vascularization of the retina. For vision screening, 6 month interval till 24 weeks, 24 months of the age need to be done for the refractions. For the hip evaluation, for DDS screening, for less than 14 weeks, UHG can be used. More than 6 weeks, the 6 months, X-ray is preferred in both sexes, and especially the spastic infants, X-ray is first year is needed to check the subluxation. And neurosonogram is required at the 40 weeks, at least corrected at least once. And for the preterm, 4 to 7 days, at the age of 4 to 7 days, and need to be repeated weekly till the things are normalized. Immunization, give the vaccination based on the chronological age, not the corrected age. Need to give full dose BCG, OPV once the baby is stable or at the discharge, and administer as per the schedule if the baby is stable. Then we come to a part, till medical part we do a fair job. Then when it comes to neurodevelopmental part, there is a lot of variation practices, and there is a lot of part, different aspects to it. But at least as far as general pediatrician is concerned, we can do the tone examination. There are few tools established and validated, but the quickest way to do in the routine practice is to see the angles with the goniometer, and it just takes less than 5 minutes to see, especially the adductor angles, popliteal, dorsiflexion, and scarp sign, with which we can see if the baby is hypotonic or hypertonic and direct accordingly. For the identification, when it comes to the development identification, the monitoring is recommended. It aims at supporting the development in all children, including the children with or at risk of delays. There is a difference between screening and monitoring. The screening is the one time and the cross-sectional process. Monitoring is ongoing and longitudinal process, and wherever possible, developmental monitoring has to be recommended and done. For countries like India, we need to have developmental tools which fits to this criteria, and such tool like an international guide for monitoring child development is recommended in ECD protocol also, and it has been validated again the Bailey, and has the high sensitivity of 0.86 and specificity of 0.39, and it's freely available and available in the local languages and easy to perform, interpret, and it doesn't require any specialized tool, but training is required. The most important, as the high-risk follow-up starts with the counseling, effective counseling, it has to conclude with a very solid documentation. So we need to have a pre-discharge checklist, and all columns need to be checked and explained, and signed should be there with the of doctor and the parent. A copy should be with the parents, and a copy should be in our records. A follow-up protocol should be on there on our paper, and we should fill it up completely. So in MAHAIP, we have the high-risk newborn assessment and follow-up program. We conducted it, started in October 22, and almost 9 workshops we conducted, and around we reach up to 310 pediatricians, and we are very thankful for MAHAIP for giving that opportunity to us. So to conclude my talk, the goals are good for setting a direction, but we need to have a system, and we need to keep on improving that system, because everyone is working in a different setup. So guidelines may not be applicable or feasible to them, but we should be always to try to give best possible care to these tiny souls, so that they can have the optimal chance to live a better and intact life. Thank you very much.
Yeah, thank you, Dr. Avinash. Very nicely explained and shown all the protocols. Regarding this, any expert comments for this, Dr. More sir or Dr. Patil sir?
Okay, Sandeep, you say something, then I'll speak.
No, actually, it's a very huge topic, but covered in very short time, and crisp it was. So only 1 or 2 points I want to add is you should have a very good monitoring protocol should be there in the form of when you are following up the child, physical monitoring and neurological monitoring. In physical, basic things comes weight, length, head circumference, and neurological monitoring, eye, ear, and complete neurological examination. For that, in which you are trained, like that we used to follow DDST charts for neurological monitoring of the child. And another thing important is you should have checklists. So before discharge also checklist should be there, signing should be there, because this will have good medical legal implications also. Kiran, you can take over.
Yeah, no, just I think the ideal high-risk infant follow-up actually involves multidisciplinary team, because especially like having a physio or sometimes speech pathologist and all those things. Many times at least one physio has to be there. So like I'm trying to even set that in India. I know it's difficult. Logistical challenges are there, and there should be a separate high-risk infant follow-up clinic, because in a daily busy OPD, it's very difficult to perform all the tests. Checklist is a good idea, as Sandeep mentioned, and Avinash very nicely showed those. I think one should have the checklist, but performing a test, again, any test is okay. There are so many the tools are available. One should be competent and thorough about it and follow that protocolized approach. And picking these babies early and then subjecting early intervention is the idea. Many times, subtle things are not picked up, and we are late. Even general motor assessment is something we had actually started doing, which is not part of the many protocols, but such a simple things to watch their videos also helps. And if you can get on one day, if sees a physiotherapist, and if some other specialties are required, then come and see you as a high risk follow up. That's always the ideal approach. So try to have like a multidisciplinary clinic. But yeah, it's a big vast topic. And congratulations, Avinash, for the modules. And I think that's very good. I think these IGMCD modules are very good and very practical also. I think and great for conducting those HINA modules. So great work. Thank you.
Yeah. Thank you, Dr. Kiran Mori sir and Dr. Sandeep Patil, for your expert comment on this. Now we will go proceed to second last topic. I will invite Dr. Harshal Wag sir for his topic on neonatal window, focus for neonates. Over to you, sir.
Yes, sir. Sir, are my slides visible? Am I audible?
Yeah.
Yeah, make it large.
Yes.
Yeah.
So I would like to thank MAHAIAP for giving me this opportunity to talk on POCUS in unit. And we have Dr. Kiran More sir, who is my teacher here for POCUS, and I'm learning POCUS from him currently. I'm the student of his in the 7th batch right now. So whatever I have learned and whatever we are practicing for the critical care management in an ICU, I would like to share a few things. So we get similar cases with us. Term baby emergency cesarean section done in view of meconium stained lacquer, and baby develops respiratory distress after birth and has tachycardia, tachypnea, Downey score of 4, kept on bubble CPAP. Our differentials are meconium aspiration syndrome, transient tachypnea of newborn, or maybe early onset pneumonia. So we get a X-ray done, and this is the X-ray picture on the right-hand side. So whether to continue CPAP, whether to increase the pressures, whether to ventilate, whether to give surfactant, or is there any presence of pulmonary hypertension? X-ray won't answer all the questions. So we need focus, point of care ultrasound. So what is isonation? Isonation is use of ultrasonography, ultrasound for examination and treatment of the patient. So after inspection, palpation, percussion, auscultation, isonation, that is use of ultrasound, has been considered as the 5th pillar in neonatology. So what basically is POCUS all about? So POCUS is an ultrasound examination performed and provided at the bedside by a primary care physician, usually as an adjunct to the physical examination, to identify the presence or absence of limited number of specific findings. So what are the advantages of POCUS? So POCUS is not here to replace the cardiology or radiology, but it is to complement it. It is performed at the infant's bedside, so no need to shift the patient anywhere. It is radiation free. It can be done in a faster way, and it facilitates towards the prompt diagnosis and intervention. So utilization of POCUS can be done for visualizing the neonatal lungs, for cranial ultrasound, for neonatal echocardiography, and for bowel and bladder ultrasound. So talking about the lungs, the diagnostic possibilities of focus for lungs. If we see respiratory distress syndrome, pneumothorax, pleural effusion, consolidation, meconium aspiration syndrome, all this can be early diagnosis and intervention can be made. So what are the advantages of point of care ultrasound when it comes to the lungs? So it gives a more sensitive information for the lung diseases. It is simple and readily accessible. Greatest utility in neonatal emergencies like pneumothorax. So it decreases the number of chest X-rays which are taken. It can be a guide in decision making for administration of surfactant and in invasive procedures like thoracocentesis. So if we see the sensitivity and specificity for the lung diseases, point of care ultrasound has a specificity more than 90% for most of the dreadful conditions in neonatology. So this is what we see when we put the linear probe on the baby's chest. These are the A lines which indicate good presence of air inside, which are the good lines. B lines indicate presence of fluid, which can be due to various reasons. The pleural line, the lung sliding, if it is absent, if it is pneumothorax. So these are very minute things which can be studied in detail. Moving on with the scope of practice towards the cranial ultrasound. So basically, cranial ultrasound plays a very important role in estimation of the cerebral blood flow velocities, calculation of the resistive index and pulsatility index, which are useful measurements for non-invasive monitoring of intracranial pressure and prognostication in case of hypoxic ischemic encephalopathy. Diagnosis of intraventricular hemorrhage useful in a crashing neonate in an ICU may be done early, and intervention also can be done for the same. So multiple indices can be used to monitor hydrocephalus. So if we see IVH, hydrocephalus, and HI, these are the most of the common neonatal conditions that we see, which can be which can be early diagnosed with the help of cranial ultrasound. When it comes to the abdominal ultrasound, it focuses specifically towards the bowel and bladder. So when it comes to the bowel viability can be assessed. Most common condition when it comes to the bowel pathologies is necrotizing enterocolitis. So the assessment of bowel peristalsis, vascular perfusion, nematosis intestinalis, portal venous gas, bowel wall thickness, and free fluid, every parameter can be assessed. It may predict surgical intervention. It may guide towards peritoneal fluid aspiration if needed. So basically, the main advantage of USG over X-ray in case of NEC is a real-time assessment of the bowel, early diagnosis, and early intervention if surgical intervention is required. When it comes to the bladder ultrasound, we can assess whether there is any urinary retention or anuria. If there is anuria, it suggests that if the baby is anuric, it might require placement of the catheter. Talking about the cardiac ultrasound, it is basically done for the preload assessment and to check for the fluid responsiveness. There is something called as diagnostic echocardiography versus cardiac point of care ultrasound. So cardiac focus is clinician driven and it assesses the cardiac function. So it is basically done to assess the cardiac function, whereas the diagnostic echocardiography is done by a pediatric cardiologist to look for the structural deformities present in the heart. So POCUS can be used as a tool for assisting the NICU procedures. So placing the central line as well as localization of the central line, endotracheal tube localization, also lumbar puncture, suprapubic tap, pericardiocentesis, and thoracocentesis. These are the invasive procedures which can be helped out with the help of POCUS. So coming to the last part of this presentation, there is this SAFE-R protocol which has been designated. So it is sonographic assessment of life-threatening emergencies, which this got revised. So it is a rapid targeted ultrasound method to quickly find out the cause in suddenly deteriorating neonate. So a baby which is deteriorating, all of a sudden We need to find out the cause after clinical evaluation. Focus can be very helpful. So with the if we see the silent features of this, a single probe is used to assess everything in emergency. So it focuses on the safe points. So safe points are these anatomical landmarks. It has a prioritized flow and gives us rapid results. So whenever a baby is crashing, so we are supposed to check all these points which have been mentioned in the picture here. So first we are supposed to look for the heart, the cardiac tamponade. Then we are supposed to look for the lungs. We are supposed to check for the sliding sign, look for the tension pneumothorax, if any, look for any pleural effusion. Then go down, look towards the abdominal aorta, look for the contractility, and then go towards the abdomen below, check whether there is any fluid inside, and then we can end with a cranial ultrasound, checking for any IVH, if any. So this is the way the safe protocol has been established. So there is a mnemonic which can be remembered. That is, S stands for subcostal, that is cardiac. A stands for aortic pulsatility, that is checking the abdominal component. F stands for fluid or effusion, and R stands for rostral or cranial. So this is how a crashing infant, this is the flow chart in which we are supposed to assess a crashing infant in an ICU. So to end with, legal aspects of focus are very important. I have a machine, I don't know what is to be done. You can't touch the machine. The first thing is your machine needs to be registered under the PCPNDT Act. If you have a machine which is registered, that's not enough. You need to have a PCPNDT registration certificate of your own. Without the certificate, you cannot touch the machine and give any reports. Candidates who have done fellowship program or few degrees like MD radiology have their PCPNDT registration done by the end of their tenure. And if you don't have the PCPNDT registration certificate with you, there are 6 month courses available, after completion of which you can get your own PCPNDT certificate, and only after that you can do practice point of care ultrasound. So with this, I would like to end my talk. Thank you.
Unmute, sir. Rishi, sir, unmute.
Thank you, Dr. Harshal. Very nicely explained regarding the focus and all. For this, I will ask for the expert comment first to Dr. Sandeep Patil, sir.
Sir, this is a very big topic. We are running and attended also the hybrid workshops for that. So each means organ, if you consider heart, we do training for around 4 days for that, and hybrid workshops will be around for 6 months that we are running. Just I want to add few points as expert. So medical legal point, I want to stress that you have to keep PCBNDT certificate. In addition, ongoing you should have zero reporting certificates. Means every month from in Maharashtra, from 1st to 5th of each month, you should produce that zero reporting certificate. You should take sign from PCPNDT office and keep file of all, because every 3 months the PCPNDT people will come and check that zero reporting has been done or no. And another thing, you have to maintain the logbook of how many sonography, brain as well as echo or lung ultrasounds had been done, and that number should be given to them. And another thing is that you should keep one chart in your OPD or in the area where you are doing sonography when is the renewal, because when the renewal is there before 6 months, you have to apply the certificate, and then only you will get, other you will have very big penalty or your ultrasound machine will be sealed. Thank you.
Thank you, sir. Dr. More, sir, you have to add on this.
Yeah, well, I think again, as Sandeep said, it's a very big topic, and we also do. This is one of my favorite topic. We can talk for very hours together, and we also do conduct courses for this for 6 months. But as rightly pointed, see, any tool, half knowledge is dangerous, and any tool we have to use with cautious. Sometime, like. There are errors, because for the focus important is your eyes don't see what your mind doesn't know. So many times, if you're not fully trained, sometimes you might miss some things and you sometimes get a false perception. And I keep selling this to my fellows as well, that, sometimes especially ruling out structural heart diseases in the middle of the night. If you are not trained, and the parents also get false perception that echo has been done. So this it makes actually there are a lot of implications and responsibility of doing POCUS. So it should be done with properly trained, and as PCPND rightly highlighted, we have to be careful. You will do 100 echoes, and one mishap will actually can really get into trouble. So one has to be very careful in record keeping, documenting, and sort of what we speak also. Yeah. So but it's a very useful tool. As he said, it's a fifth tool. So many times, before even oscilloscope, sometimes we have a probe. We quickly assess things, and I think safer protocol, crashing protocol, whatever, quick way of assessing things. And we also sort of follow same thing. Once you finish, quickly do an echo, head scan, lung scan, and within 5 minutes we can screen a lot of things. So I think it's a very, very important skill to have. Everyone should probably try to pursue it. I think that's it from my side. Well done, Harshal. Nice presentation.
Yeah.
Thank you.
Thank you for Dr. More sir and Dr. Patil sir for your expert comment. Now I will hand over to Dr. Sachin Patil for further proceed.
Yeah. Thank you, Rishi sir. I think some questions are there. Yeah, no. I think one question was there for propylcetonin, which was already taken
Yeah.
up. Dr. Meena sir, Dr. Bakmod sir, do you want to add in the discussion? I think so. Okay. Then we'll go ahead with the vote of thanks.
Wonderful presentation by
Acha,
all
sorry,
the
sir.
presenters, and at the same time, the expert comments from both the experts, Dr. Kiran More sir and Dr. Sandeep sir. And really, it has enriched our knowledge of neonatology. And all the attendees who have attended the today's MAHAIP sessions, they will definitely be benefited from the presenters' presentation and as well as the experts' comments. And after the program, also this will be available on the MAHAIP website. So means later on, if anybody want to go through this, means he will be able to go through the all the means topics of the 5 topics today covered in today's Friday Ka Panch Mahayapika Sangh. So once again, I thank you, Dr. Kiran More sir and Dr. Sandeep sir, for your valuable presence for the today's program. And all the 5 presenters, they have presented beautifully, and in the very short time, having such a speaking on hypoglycemia, speaking on focus. I mean, every as the experts have already said, there itself is a one topic. Means a day-long discussion can go on over there. So we are covering in such a short time, but still you have given a justice. You have done justice with the topic. So once again, I congratulate all of you for the wonderful presentations. And over to you, Sachin.
Yeah. Amol sir, do you want
Yes,
to add?
thank you. Nothing more.
All the best for the new role, sir, for 2026. Vice President MAHAIP.
Thank you. Thank you.
Welcome.
Thank you, Kiran sir. Thank you, Sandeep sir, for your efforts in making this program successful. Thank you, Avinash, and all the speakers. Harshal, thank you, Rishi sir, Sandeep also, Sachin also, and everyone, all the attendees. Thank you.
Thank you, sir.
Yeah, well done, our presenter.
Hello,
Thank you.
good
Now-
night and
Thank you,
happy
Harsh.
New Year.
Thank you
Vote
for
of thanks.
inviting. Thank you,
As we
everyone.
wrap, sir, one minute.
Yes,
As we
yes.
wrap up this insightful session on neonatology in pediatric office practice, I would like to take a moment to express my heartful gratitude to our speakers, Dr. Ganesh, Dr. Padma Sinha, Dr. Vipul sir, Dr. Avinash, Dr. Harshal. Thank you for sharing your expertise and enriching our knowledge. To our expert, respected Dr. Kiran More sir, Dr. Sandeep Patil sir, appreciate your valuable insights and guidance. And today's guest of honor, Dr. Sanju Joshi sir, Dr. Vinayak Patil, Dr. Renu madam, thank you so much. Most thank you to our team, Dr. Pakmode sir, Dr. Amol Pawar sir, and all EB members, and my co-moderator, Dr. Rishi Loda sir. Thank you so much. Thank you so much, all the delegates, and wishing Happy New Year 2026. So good night and thank you so much. Once again,
Thank
Happy
you.
New Year.
Thank you, Sachin and Rishi.
Pallavi ma'am,
Yeah.
And
Happy New Year to all.
Yeah,
Yes,
Happy New Year.
everyone, Happy
Good
New
night.
Year.